Hello. Yes, good morning, one and all present here. Myself, Dr. Mansi Patel, Assistant Professor at BITS Institute of Physiotherapy, would like to welcome everyone in today's webinar. Today, we are going to cover about basic anatomy, classification of ankle sprains, clinical course, risk factor, differential diagnosis, examination and rehabilitation of ankle injuries. It is my privilege to introduce today's presenter, Dr. Akanksha Sojitra, Masters in Kinesiology and Clinical Exercise Physiology from Texas A&M University. She is licensed physical therapist in the state of California, USA. She is certified manual physical therapist and orthopedic certified specialist. She is pursuing fellowship in orthopedic manual physical therapy and she is APTA certified clinical instructor. She is selective functional movement assessment certified and dry needling specialist. She is having more than 5 years of experience in the field of outpatient physical therapist. Before starting the session, I would like to tell that we will be having live question answer session at the end of the topic. At that time, you can ask question in the message box. If you miss anything, don't worry. We will put this session on our YouTube channel. Before starting the session, I request to all participants to put the microphone on mute mode and please don't share your screen to avoid chaos. Now, without wasting much time, I would like to request Akanksha Madam to start the session. Over to you, Madam.
Um, Thank you very much, BITS Institute of Physiotherapy, for inviting me, and thank you, Mansi, for such a nice introduction. Hi, I'm Akanksha. So I'll get the presentation started for today, which is on ankle stability and movement coordination impairments. So I'm going to cover main clinical practice guidelines, which are based on the recent research, and this practice guideline was published in 2013 by APTA. So this will go over what are the current evidence in looking for lateral ankle sprains mainly. So today I will cover anatomy, incidence of ankle sprains, classification of ankle sprains, and mainly covering the lateral ankle sprain and its clinical course, all the risk factors that affect it, the diagnosis, and all the differential diagnosis that you need to look for, examination and physical impairment that you need to look for in a patient, and rehabilitation, which is in protected motion phase and progressive loading. So anatomy, we all know like ankle joint is stabilized by three main things: the osseous congruity and the fit of articular surfaces when the joints are loaded. That's our tibia and your talus. The static ligamentous and the capsular restraints, ligaments which are the lateral medial, and the capsule of your talus and your tibia, and the surrounding muscular tendinous units, all the muscles surrounding the joint. Usually the lateral ligaments of the ankle are potentially injured with an inversion and supination mechanism, and that's the most common mechanism that we see, which affects this which affects the foot and sports injuries. Now, going for incidence. So ankle sprains are, you can see almost 2 per 1,000 people in a year in general population. Usually you can see it between 15 to 19 years of age. There is no difference between genders. Half of them occur during athletic activities, basketball, football, soccer. Football here is different in America. So you see most of the ankle sprains there. And ankle injuries account for 10 to 34% in all the sports-related injuries, especially lateral ankle sprains, which are the maximum, almost going to 80%. Okay, classification. So ankle sprains are classified mainly in like lower ankle sprain and your high ankle sprain. Most of the time, what we see clinically is your lower ankle sprain, which is the lateral ankle sprain, that's 80 to 85%, and the medial ankle sprain, which consists of almost around 5 to 10%. The high ankle sprains, which are the syndesmotic sprains, they are less likely, but you do see them clinically at times, and that's 5 to 10%. Now, lateral ankle sprain. Most of the time, as I said, it's the plantar flexion, and you see the invert twist when the ankle gets sprained. And almost 80% of the time, you'll see ATFL getting sprained. That's your anterior talofibular ligament, which goes from your fibula to your talus anteriorly. And more stronger forces on that inversion sprain can also injure the calcaneofibular ligament, which goes from fibula, but it goes a little bit more posteriorly and attaches to the calcaneus. Now, medial ankle sprains. As we know, medially in ankle, we have the deltoid ligament, which is a very strong ligament, and it doesn't get injured as easily. You need a higher force, an eversion, to get that ligament injured. And it can cause damage to the structure, but more commonly it may result in avulsion fracture of the medial malleolus. Now, high ankle sprains, that's the syndesmotic sprains. These happen when you land, at times in a dorsiflexion and an eversion mechanism, and cause sprain of that syndesmotic structure, which is formed by the tibia and fibula. These generally tend to be less swelling in the high ankle sprains, and you can do the squeeze test to find out if there is a syndesmotic injury. Syndesmotic ligaments contribute to chronic ankles instability. So those ankles where you see a lot of sprains over a period of time or consecutive years, that's where you're suspecting a syndesmotic injury. Okay, so now I'll go over the grades of ankle sprain, how to identify if this is a grade 1, 2, or a 3. Usually with grades, you are looking at how the patient is presenting. Is there a mild swelling and tenderness? With grade 1 sprain, you will see micro tearing of the ligament. There is no joint instability on examination, and patient is able to bear weight, and they'll walk inside your clinic, and pain would be minimal to moderate. Also, there is no loss of function, and ligamentous laxity also is less there. So when you do the anterior draw test or talar tilt test, you won't see much. The test would be negative. You see more mild tenderness, not much laxity there. Now, grade 2 sprains. This is what we see a lot, which is partial tearing of the ligament. There is moderate tenderness and swelling around the ankle. You can also see ecchymosis, which is that purplish color that you see in ankle sprains. There is mild to moderate joint instability. So now then when you do your anterior draw test or talar tilt test, you would see a little laxity there, but you'll still get an end feel when you do the testing. Weight bearing and ambulation are painful, but patient would still be able to bear weight and come into the clinic. Now, grade 3 sprain. There is almost near to total loss of function with grade 3 sprains. And you will see a positive anterior draw, positive talar tilt test, and there will be a lot of laxity when you do these tests. So most of the time, it's a complete tear of the ligament. They have excessive tenderness and swelling. And these grade 3 injuries are further divided into grade 3A and 3B, where the 3A and 3B are divided based on the movement on anterior draw. If you see a 3 mm or less motion in the anterior draw, you can consider it a 3A. And if the laxity is a lot and you do not get a good end feel, you get that boggy end feel, then that's a 3B. Okay, so before I go over the lateral ankle sprains, I'm going to go over a case just to see what you're thinking with ankle sprains and what are your clinical reasoning. So in this case, there's a patient called Amit who comes to your clinic. He's a 25-year-old, sprained his left ankle playing basketball at a local recreational center this morning. And he came to you directly without seeing any healthcare provider. You see edema on the left ankle, primarily on the lateral side. He's unable to bear the weight on a significant amount of weight on the left lower extremity when you get him to do single limb stance. And gait is painful, and pain is 4 out of 10 on average and 9 out of 10 worst. He's in good general health, reporting only a prior history of low back pain that was 4 years ago. He stays active by playing basketball at least 3 days per week and reports a prior history of 3 sprains to the same ankle, and most recent was 9 months ago. So in this case, I'll keep this page for a few more seconds if you want to read over this. Okay, so in this case, what do you think? Which of the following examination findings would serve as a contraindication to low-grade passive ankle and foot joint mobilizations for this patient? Would you say ankle edema, ecchymosis, ligament tenderness, or midfoot tenderness be a contraindication? We can go over the answers once we finish and come back to this slide. Okay, so lateral ankle sprains. There is partial or complete disruption as we went over the grades. And most often you see ATFL, that's anterior talofibular ligament, calcaneofibular ligament, and posterior talofibular ligament that's injured. And most of the time, it's an isolated injury of ATFL. Okay, now what's the recovery time when you see lateral ankle sprains? With grade 1, you're looking at 7 to 8 days. With grade 2, you're looking at a recovery of 2 to 3 weeks. Grade 3A, you're looking for almost 30 days and even more. And 3B, you're looking for almost 60 days. Okay, now ATFL. So this ligament, as I went over in the picture, it's right here where you see from fibula going over to the talus anteriorly. And it's an extra-articular ligament, which doesn't come in the joint capsule, provides primary restraint to inversion movement when the ankle is in plantar flexed position. And there is 50% avulsion from the fibular end, and mid-substance tears are 50%. You will see lower maximal load tolerance before failure compared to other structures. Okay, now calcaneofibular ligament. As you can see here, from fibula to calcaneus, the vertical ligament that's going right there is the calcaneofibular ligament. It resists your supination, that's your inversion, at both the mortise and the subtalar joint. Now, posterior talofibular ligament. It's a bigger, robust, and a broad ligament, which has high tensile strength, and it provides resistance to inversion and internal rotation. That's of the calcaneus. Injury to PTFL is least likely to occur. So, why are we doing these stability tests? And what are why do you want to stress test these ligaments? Mainly that to know if the ligaments are torn, and 2 reasons are that you see an increase in pain when you stress test. Also to test how stable they are which grade they are in, and is there an abnormal accessory glide or motion. Now stress testing. So I'm sure you would have gone through all the stress testing for the ligaments in your orthopedic section. I'm just going to quickly go over all how the testing is done. For ATFL, you bring the ankle in plantar flexion, inversion, and you provide a general traction. And then you're looking for the gapping of the joint, and if you're looking if there is end feel or not. For calcaneofibular ligament, you bring the ankle in dorsiflexion and you create a pure inversion because it's more of a posterior ligament. And for posterior talofibular ligament, again, you're trying to stabilize the tibia, and then trying to create an internal rotation force. For anterior deltoid, so for the deltoid, you are going to create an eversion because deltoid is medially. So there with anterior, you're going to plantarflex it and evert and then give a traction. For middle, you dorsiflex and then give a pure eversion. These are isolating all the deltoids. And then for posterior deltoid, you're creating a dorsiflexion, and with the traction, you are creating a direct pull on that mortise. Now, the squeeze test, that's usually done for syndesmosis injuries, where you compress the proximal fibula against the tibia to assess the integrity of bones, and the intraosseous membrane and the syndesmotic ligaments. Pain occurs with fracture or diastasis, where the intraosseous membrane separates the two bones, and then it's considered positive. Squeeze test is pretty reliable and has been found to be moderately reliable clinically. Now, stability of ankle. As we went over, right, ankle is stable because of all these ligaments, and we have the dynamic stabilization, which is also dependent on muscles. And laterally, you see the fibularis longus, that's your peroneus longus and brevis. And you see tibialis anterior, extensor digitorum longus, which act eccentrically to control the plantar flexion. And reflex reaction is slow to protect the injury, but your anticipatory reaction will help in preventing the injury in your ankle. Now, if you have an injury of ankle, what will it lead and what will it cause to local muscles and the remote muscles? You'll see weakness in the local foot muscles. That's why we do all those foot strengthening exercises with the band. But you can also see remote weakness in your lumbar spine, in your hip, where you see glute max weakness, biceps femoris. You might see sensory changes in the joint receptors and nerves like sural nerve and superficial peroneal nerve. So these are all the combined things that you see when you have an ankle injury. Now, clinical course. What happens clinically over a period of time when you see ankle injuries? There's rapid decrease in pain and improvement in function the first 2 weeks after the injury. Almost 30% of patients continue to have pain at 1 year mark, and 5 to 25% still experience pain after 3 years. Residual problems, that's pain and instability, crepitus, weakness, stiffness, and swelling. These are the things that you can see over a period of time, which eventually lead to chronic ankle instability. And full recovery, you're expecting at approx 50 to 85% at 3 years after the injury. And it's independent of the sprain severity. So if you do not go through a proper rehab, there is a high chance of getting into a chronic ankle instability. Okay, now clinical features. What do you see when the patient presents? As I went over, you see pain at rest, at times at weight bearing, swelling, redness, ecchymosis, you see instability, weakness, impaired proprioception and postural control. That's why you see the weaker muscles up the chain in your lumbar spine and your hips, and activity limitations and participation restrictions. They might have activity restrictions just with walking, baby steps, or with higher activities. Now, what are the risk factors for ankle sprains? What are the risk factors you're looking at for progressing? History of previous sprains, which is chronic ankle instability. So your prognosis will be bad. Gender, usually we tend to see ankle sprains in younger females and older males. And this is from the latest research. I don't know why. It's in younger females and older males. Also physical characteristics, height, weight, body mass index. Those also play a role in risk factor for ankle sprains. Musculoskeletal characteristics. So if you have problems with balance, proprioception, range of motion, if your ankle dorsiflexion is limited, or you have limitation in motion in your knee, there is a chance of ankle sprain. Strength, anatomic alignment, and ligament laxity. Now, extrinsic factors which can impact, uh, they are your footwear or any external support you're using, type of sport a person plays, level of competition, if it's a highly competitive athlete and it's not taking any rest in between, participation in neuromuscular training, if there was a previous ankle sprain and did they participate in a full rehab of balance training and neuromuscular training or not, surface of play, what kind of surface they're playing, is there more impact, and inadequate warm up or cool down. They directly jump into an activity without doing a warm up. Now, for diagnosis, a lot of tools are used clinically and which have good specificity and more reliability over a period of time. You can use the ankle instability equivalent instability tool, which has good sensitivity and specificity of almost 80%. And ankle instability instruments, which has 12-item questionnaire, and functional ankle instability questionnaire. It also goes over different functions, and so you can track the progress of the patient. Now, for differential diagnosis, what do you need to know, pathology-wise, that can happen at ankle, and which could be differential diagnosis? Syndesmotic injury, which we saw earlier, cuboid syndrome, peroneal tendonitis or tendinopathy, any sensory nerve injuries, medial collateral ankle sprain, Lisfranc fracture or dislocation where you have the fracture of the midfoot, subtalar sprain, spring or bifurcate ligament injury, Achilles tendon rupture, lateral talar process injury, and anterior process of calcaneus injury. Okay, so what should you do in the examination, and what's clinically and research-wise, what are the steps that you should take for examining a lateral ankle sprain? First things first, you're going to look for posture, see how their ankle is aligned. Are they in supination? Are they in pronation? Do they have calcaneus valgus or varus? What kind of footwear they're wearing? Also, physical impairments, are they limping or do they have Trendelenburg? So you're going to look at normal gait analysis. Swelling, is there a local swelling? Are they not able to bear weight on that foot? Ankle range of motion and your foot supination, pronation ranges, and normal strength testing that we do, dorsiflexion, plantarflexion, inversion, eversion, isokinetic testing. Okay, and now for ankle sprains, for lateral ankle sprain, what are the special tests that you need to perform? Anterior draw test, where you're trying to take the mortise of talus and trying to translate it anteriorly. The amount of translation and eventual weakening of the end field, changing from harder ligamentous to the weak, is observed here. And you're comparing it with the healthy contralateral part. Here also, same thing, you're looking at translation, how much it is, do you get an end field or not? Okay, now that's the talar tilt test. For talar tilt, foot is positioned in that 10 to 20 degrees of plantar flexion, and you are stabilizing the distal leg and trying with your lower hand to invert the foot, and you're stabilizing the malleolus with the other hand. The lateral aspect of talus is palpated to determine if there is any tilting, and laxity is compared again to the other side. So you want to test the contralateral limb first and then test this leg. Also, this test is will let you know if there is sprain of your calcaneofibular ligament. And when the talar tilt test is, you see almost 15 degrees or more than compared to the other side, that's when you know it's positive. It's more of a comparison, and same like the previous one, you're looking more for the end field. Are you getting a hard end field? Okay, so for balance testing, single leg balance test has been pretty reliable. You can do this in the clinic easily with eyes open, eyes closed, 1 minute each, and test and retest this pre and post your rehab. And for more dynamic and challenging activities, you can measure the functional balance. You can do the STAR excursion balance test. Now, after doing all this for doing all these examinations, you still need to do something. You still need to know something before you jump into any of this, right? Your history, and any of the examination is usually sufficient to diagnose, but sometimes radiographs are necessary. Sometimes you need to know if X-ray is needed or not in the case. So for that, we'll go over Ottawa rules and the Bernese ankle rules next. So what are Ottawa rules? Just tells you if a radiograph is needed, and if there is pain, if patient presents with pain, and with an actual ankle sprain or a fall, you need to know if they have tenderness along the tip of the posterior edge, distal like 6 centimeter on the lateral malleolus, tenderness on the medial malleolus, similar almost 6 centimeters, inability to bear weight, and if they can't walk for 4 steps, and pain in the midfoot area near the navicular, or if they have that fifth metatarsal base tenderness. Now, Bernese ankle rules. These are used to same as Ottawa ankle. They are also very good specificity wise and sensitivity wise. Here you're looking at indirect fibular stress, 10 centimeter proximal to the fibular tip. So same thing, you're looking at the lower end of the fibula. Direct malleolar stress, you're trying to apply the malleolar stress and see if that's producing any of the symptoms. And compression of the midfoot and the hindfoot, if that produces symptoms after a sprain or injury. Now, for outcome measures, which ones are, what can you do objectively to assess meaningful changes in the score over time? Foot ankle ability measure is pretty reliable, and it's just a questionnaire where you can use in the clinic. Foot ankle disability index, lower extremity function index, which is commonly used in the clinics. Chronic ankle instability scale, sports ankle rating system, and ankle joint functional assessment tool. So these are all the outcome measures which have shown clinically and research-wise good outcomes eventually over a period of time. Now, examination. Along with what we did previously, gait and observation, and doing your normal stress test, single leg stance test, what are the things that you can do? Activity limitation and participation restriction can be measured further by side hop, 6-meter crossover hop. So this is more for a functional individual. 40-meter walk time, 40-meter run time, figure of 8 run, single limb forward hop, crossover hop, and stair hop. Now, activity limitation and participation restriction measures that we just went over, they have they are recommended well, and there's a grade B recommendation, which is high research-wise. When evaluating a patient in a post-acute period following a recent or recurring ankle sprain, you can use these tests. Now, observation of movement pattern during a single heel raise test. So when you do you can also do a single heel raise test and look for heel height, look for how the knee and trunk is positioned, and see if there is excessive knee flexion, trunk flexion, are there any compensations, just to see if there is any other muscle weakness while you test this. So this can help you with interpreting if there is any other muscular weakness combined with your acute injury, or if you have a patient who's presenting with recurrent ankle sprains. And first metatarsal plantarflexion, dorsiflexion, is there enough first metatarsal movement? Do they have good push off? Also, the dorsiflexion range is it good enough for the gait? So these things that can be observed during the movement of a single heel raise test, and it's a pretty good test to use clinically. So you can look at the patient and try to see if there are any compensations in the chain in your hip, knee, ankle. Now for rehab, for acute protected motion phase, the initial acute patient, early weight bearing with support is clinically reliable, and all the 1 and 2s that you see here, 1 is the highest clinically evidence-wise you're at 1, and then 2 is also pretty good, but 1 is at a higher level. So early weight bearing with support, external support like a brace, even tape, and any of them can be used. Brace has been found to be better than taping. Cryotherapy, you can use ice. Manual therapy has great too, clinically, and pulsed diathermy can be used. Electrical stimulation can be used. Laser also is good. Ultrasound has no benefit, so it's 1 on no benefit. So there's no need of using ultrasound at all for ankle sprains. Therapeutic exercises, it also has a grade 1 evidence. You can do active range of motions, progressive resisted exercises with your bands, and progressive weight bearing, incorporating more functional movements. Now, progressive loading. Again, in this phase, where you're trying to move out of that acute phase and they've advanced in the ranges and everything, you can start doing manual therapy, which has very good evidence. Clinical prediction rule to predict likely rapid responders to manual therapy, and subjects meeting any of the 3 of the 4 criteria given here were up to 95% likely to respond favorably to intervention within 3 treatment sessions. So worse symptoms with standing, worse symptoms in the evening, navicular drop test of 5 mm or more. So you're looking at the navicular height in the collapse and in once they're standing, and checking if there is enough difference. Hypomobility of the distal tip joint. So any 3 of these 4 are present, they're likely to respond to manual therapy. Now, the manual therapy, you can do your normal AP glides to achieve the dorsiflexion, or you can do the Mulligan mobilization with movements, which has been found to be very reliable, and you can get more good results with that to gain the dorsiflexion range. You can also use subtalar mobility to get the eversion or the inversion, whatever they're lacking. So in progressive loading phase, even therapeutic exercise and activities have grade 1 evidence. So you can do the range of motion exercises if they have any remaining limitations, weight bearing and functional exercises, single imbalance activities, and now can be progressed into unstable surfaces, and exercises to improve mobility, strength, coordination, postural control. So you can start challenging them in progressive loading phase. Now, going back to your case, which of the following manual therapy would you use in that case? I'll go back to the case. Give me 1 minute. Okay, so this was your case. So the 25-year-old and who sprained his ankle playing basketball, and 4 out of 10 average pain and 9 out of 10 worst pain with walking, and there's some edema, some tenderness, and ecchymosis. So which of the following findings would you are the contraindication? And what would you use in this patient for an acute protected motion phase when they present acutely? Okay, we can go over the answers. So So that's about it. So scope of learning from these clinical practice guidelines is you can refine your assessment skills. These outcome tools are there, which can be used clinically. You can try it in the clinic and see how it works for you. All the functional assessment tools also see if that works for you over a period of time, pre-rehab and post-rehab, and try the special tests on patients. I'm pretty sure you've learned that in the clinic, and other differential diagnosis, if you can diagnose or go over what are the symptoms of the other diagnosis. And these are my references. Okay, any questions for me?
If anyone is having any question, can write in the message box.
Okay. Should I discuss the answers to the cases, or should I skip that? Because I don't see any answers.
You can discuss that, madam.
Okay, so let's go over the first question. So that's your case, right? And so what's the contraindication for normal passive foot mobilizations for this case? So edema and ecchymosis, you usually see this, and they're very common in the initial days of normal ankle sprains. Ligament tenderness is also expected. It's even expected later phases. Midfoot tenderness, that's where you have to be suspicious and need to know where it is tender, and rule out if it's rule out your Ottawa ankle rules and see if they need to be referred, and do they belong in your clinic. And for the last case, what would you use in manual therapy? So for manual therapy, you would use not do a manipulation, right? It's an initial acute phase. So you would want to do a mobilization with movement, and try to use that because you would likely respond to a slow velocity mobilization procedure rather than a MINEP, which is a grade 5 mobilization. All right.
Okay, if anyone is having any question, you can write in the message box in a minute. Fine, I think no questions, ma'am. It is very well explained from your side. So, on behalf of entire BITS Physiotherapy team, I like to thank you that in spite of your busy schedule, you grabbed some time for us and share your valuable knowledge with us. Thank you so much, ma'am. I
Thank you,
extend my
Mansi,
thanks.
and thank you, Mr.
I extend my thanks to our Honorable Founder President and Chairman Shri Jagdish Bhai Patel sir, our Joint Managing Trustee Srimati Kamalben J. Patel Madam for their constant guidance. I also like to thank our CMD Shri Dhruv J. Patel sir and our Campus Director Shri S.K. Patel sir for their support. I like to extend my thanks to our Principal Dr. Mehul Jadhav sir and Vice Principal Dr. Sarfaraz Nawaz Shah sir for their constant encouragement to do such events. I want to extend my thanks to Avni Vasant Madam, HOD Computer Department for technical support, and respected Gade Dada for wonderful graphic design. I thank all the faculty members without whose support it is not possible. Lastly, I want to thank our participants for showing their interest in the session. I once again thank everyone for making this program successful. BITS Institute of Physiotherapy would look forward to see you. Thank you. Have a great day. Thank you, ma'am.